Okay, I welcome everybody on behalf of Federation of United Doctors. I welcome the students and all the co-hosts. Today, our topic of discussion is topic was written as examination of lungs. Perhaps it has come as per demand from students. Chapter is actually examination of the respiratory system, and today our teacher is uh, our esteemed teacher is Indranil sir. He is departmental head, Department of Chest, College of Medicine and JNM Hospitals, Kollani, and he is a very renowned teacher, and he will be delivering his speech. So I hand over the podium to Indranilda from now on, and thanks to everybody for being a part of this initiative.
So thank you, Somojyoti, for your kind introduction, and good evening, everybody. In fact, I didn't expect that I'll be taking such an topic here on the Zoom, because it's basically a bedside clinics which I love to take, and I'll be enjoying to take a bedside clinic. But still, for the last 6 months or so, the world has been upside down with this pandemic, and we are all in the new normal. So let us cope up with it. Why a respiratory system is very, very important for you undergraduate people, and I know that a few postgraduate students are also here. For undergraduate, I'm telling you, every third of you will get a long case of the respiratory system. It is so common in that. In fact, half of you will be, or more than half of you will get a short case with the respiratory system. So you should know details of the respiratory system examination. So you should be happy if you get a respiratory system examination case. Not only that, in your real life also, knowing the respiratory system or the diseases of the lungs or diseases of the respiratory system is very important. Why? So if you just consider here, if you see the top 3 out of 10 leading cause of death in the lower and the middle income countries are related to the respiratory system, which include the lower respiratory, COPD, tuberculosis. So about 15.2% of the all death are caused by diseases related to the respiratory tract. It was in 1990 where world top 10 killers was there in the respiratory system. You can see the lower respiratory infection, COPD, TB, and in 2020, you'll be seeing that COPD is the third leading cause of death in that way. If you see all other diseases, the coronary heart disease, stroke, other cardiovascular diseases, or all cause diseases, there is a decrease in the death rate if you see. Whereas in COPD, there is a staggering increase in the death rate. This is because we need a lot of drugs, we need a lot of research works, we need a lot of dedication for these lung diseases, mainly when it comes to COPD. In India also, respiratory diseases are also huge. If you strength of asthma and COPD disease, it is somewhat more than all other disease, chronic non-communicable disease, combined ischemic heart disease, diabetes and everything. And so the combination is more than that. And in fact, chronic respiratory disease, the mortality when it comes to non-communicable disease, it is just one step back to injuries, but the combined cause of death, ischemic heart disease, stroke and all, it is more than that. So coming to our respiratory system, what I will do in the next 1 hour or so is take you through some of the basic anatomical knowledge, which you already have studied in your anatomy class, basic physiological parameters, the normal history taking, why it is somewhat different from the normal other history taking that you take in your medicine classes, and then I'll come how you examine the respiratory system. Though a bit of theoretical discussion, but I just promise you that I'll come up with a video in our next class how we examine the respiratory system. So when we take a history, be it in a respiratory system, a neurology case, or a cardiology case, the most important thing that we keep in our mind is a very good history taking. When we get the history, we can localize where is the disease. For example, when we take the history, we localize whether it is really into the respiratory system or respiratory system and other system are involved. Not only that, a more anatomical localization, which part of the respiratory system, is it the conducting airways or the pleura or the alveoli, or it includes some combination of these, or the interstitium also is involved. And then what are the physiological changes that are occurring in that respiratory system, and narrow down our differentials by the examination and by the investigation. That's the way that we also find out a diagnosis in real life. So coming to our respiratory system, it consists of the conducting zone and the respiratory zones. The respiratory zone, it is the site of gas exchange, and it consists of the bronchioles, alveolar ducts, and alveoli. The conducting zones, just as it carries the air into the respiratory zone, they are rigid conduits for air to reach the site of gas exchange, and includes all other respiratory structures, the nose, it starts from the nose, the nasal cavity, pharynx, trachea, and there are the respiratory muscles, the diaphragm and other muscles that promote the ventilation. Just basic anatomy for you have to know in order to start the examination. The right lung divided by the horizontal and the oblique fissure into the upper, middle, and the lower lobe, and the left lung by the oblique fissure, as you see here, the oblique fissure dividing into the upper and the lower lobe. But still we have the lingular segment, which is important as such, not for the clinical examination, but only for when it comes to radiology. And each lobe, you can see the bronchopulmonary segment, which it is important for you to remember, not at least for the examination purpose, but when we will be understanding how to interpret a chest X-ray, or in fact, when someone does a bronchoscopy, he has to see each bronchopulmonary segment. For example, in the right side, you have the apical posterior anterior, in the middle, the lateral medial, superior anterior basal, medial basal, lateral basal, posterior basal. So these are something which you have to remember. So now coming, the diseases that happens in the lungs, it involves the airway, the lung parenchyma, the pleura, or the chest wall. So now comes basic history taking. When it comes to the basic history taking, I'm not going in details of the history taking, otherwise we cannot finish up the examination of the respiratory system. But what is very prudent from the history taking is, first of all, the occupational history is very, very important, because we find a lot of occupational exposure causing pneumoconiosis or occupational diseases. For example, a person who is employed in a jute industry or a cotton industry, jute bicynosis or bicynosis may happen. A person who is exposed to a coal miner's lungs may be happening, or stone crushing industries, he may have some form of silicosis, or asbestos industry, exposure to asbestos and asbestos diseases like that. So occupational history is very important. One important history which always we ask in the respiratory system, in fact, when we write up the name, age, gender, the residence and everything, the smoking history, we write it in the, because we do not come back into this social history and again write the smoking history. I'm telling you, I'm not going in details of each and everything here in the history, but what is important in smoking history is the age when the person first started smoking, how long he or she is smoking, what type of smoke, whether it is biri or cigarette or chilam or something other than that. And ultimately, we try to come to a pack year of smoking. The basic thing of pack year of smoking is 20 cigarettes per day for 1 year is equal to 1 pack year. Knowing fully well that biri is more dangerous than smoking, or at least we can say that 3 cigarettes is equivalent to 1 biri. In that way, the harm that is caused by biri is more. And trying to come back into pack years is also important. So another 3 terminologies or 4 terminologies I'll come here in terms of smoking is never smoke. A person who has never touched that cigarettes or biris or any form of smoking, or at least has smoked less than hundreds in his lifetime. Ex-smoker, there are different definitions, but the one that is accepted is he who has quitted smoking for the last 6 months. And current smoker means either he is smoking or has smoked, he has left smoking just not more than 6 months. I'm not going into heavy smoking or light smoking. These are not some definition which you can quote, but pack year is something which is expected, and you can be asked by your examiner what is the pack year of smoking, because some of the disease, for example, COPD is related to pack year of smoking. So coming to symptoms. So in fact, the respiratory system has only a few symptoms which you should inquire and try to elaborate. These include the cough with or without expectoration, the respiratory distress, the hemoptysis, chest pain, tightness or heaviness of the chest. There are different terminologies that the patient may be using it, but these are the basic things which the patient comes with. And on examination, there may be increased respiratory rate, tachypnea, cyanosis, clubbing, lymphadenopathy, which I'll come and explain. Just when it comes to cough, again, this is something which you all have to know. What are the things that you have to ask in cough? That is from the time onset, from when is the cough occurring, whether it is an acute, subacute, and chronic. By knowing that, you can narrow down your differentials. So what is an acute cough, which is less than 3 weeks? What is the chronic subacute cough, 3 to 8 weeks? And what is chronic cough, more than 8 weeks? So if you go by that, you see, so acute cough, these probable differentials are normally upper respiratory infection, maybe a pneumonia, pulmonary embolism, or heart failure, congestive heart failure. The subacute may be because of some viral infection, mainly post-infective, sometimes post-nasal drip, or a gastroesophageal reflux disease. But what is important is, in evaluation of chronic cough, here comes a lot of differentials. Pulmonary tuberculosis is one of the very important things which you should know, that in this subcontinent, chronic cough, one of the infective cause is tuberculosis, but for the programmatic purpose, revised National Tuberculosis Control Program, here cough more than 2 weeks, you have to evaluate with a sputum for acid fast bacillus, and then see whether the person is having tuberculosis or not. In fact, asthma, COPD, the obstructive lung disease are the two common cause of chronic cough. Malignancies, bronchogenic carcinoma, eosinophilic bronchitis, post-nasal drip, GERDs, drugs, or heart failure. Just to give a theoretical aspect of this here, so question may be asked, a person who is having chronic cough is normally evaluated with a chest X-ray. So if a person has a chronic cough and a normal chest X-ray, what are the differentials? The first thing that you should know is drug. You should inquire about ACE inhibitors. The next thing comes about obstructive lung disease, obstructive airway diseases, which include asthma, COPD. Then comes post-nasal drip and GERD. And lastly, habit cough or tick cough. These are something which you should know, that a chronic cough without any localizing sign in the chest X-ray may be some of this. So again, the diurnal variation of the cough is to be inquired, whether the cough is increased at night or which time of the day. For example, if a person tells that he is having nocturnal cough, the few things that we come to our mind is post-nasal drip, GERD. And how do we differentiate between a post-nasal drip and GERD from the history itself? If the patient tells that, the patient starts coughing once he lies down, and then ultimately his coughs and ultimately wakes up, and this cough ultimately leads into vomiting or something like that, probably it is GERD. The post-nasal drip, he starts coughing, and ultimately the patient goes to sleep without any vomiting. Nocturnal cough may be also because of COPD, asthma, because an obstructive sleep apnea also. Why in asthma and COPD there is nocturnal cough? Because of the diurnal variation in the diameter of the airways, it is really narrowed, more narrowed during the early part of the, in early morning, very early morning, or at night. And because of this obstruction, there is nocturnal cough. In fact, ventricular failure, aspiration may also cause nocturnal cough. So in addition to the cough, so before going to the nature of the sputum, about something about the cough, which I am not describing in details here, but the nature of the cough, whether it is just barking type of cough or dry cough or moist cough, is also to be taken into account. So there are some differentials which are dry cough, which are moist cough. So dry or moist is very important. So coming to that, along with the cough, is there any expectoration or not? So if there is expectoration, just inquire about the consistency, amount, color, postural variation, and whether there is any smell or not. So what is important about the consistency? Most important, or four factors, consistency are normally inquired about, whether it is serous, mucoid, mucopurulent, or hemorrhagic. Hemorrhagic has not been entered here, but hemorrhagic also, which I'll describe in the hemoptysis part. Serous means it is just whitish in color. Don't write white colored expectoration, but write serous expectoration. That is important because white is something not accepted by the examiner. So where do you get a serous expectoration? It is usually because of upper respiratory infection. Bronchoalveolar carcinoma may produce copious serous expectoration. Mucoid, chronic bronchitis, asthma. What is the difference between mucoid and serous? Serous means frothy, and mucoid means somewhat whitish in color, similar what we call in Bengali talsas type cough. Talsasher moto cough jodi bole, that is mucoid cough. Some mucus impacted in bronchus that comes up. Mucopurulent means bacterial infection is there, but sometimes without even bacterial infection, if there is neutrophilic infiltration, it produces mucopurulent. So again, with this, the amount of the expectoration, how much amount is important. In fact, look at the cup that is there, because this is sometimes examiner may ask for. And always see the cup, see the color of the sputum. That is important. Sputum cup may be kept beside this patient, and in the undergraduate you may be excused, but in postgraduate it was very important that you look at the sputum cups, note the color and the amount. So where do you get a copious amount of expectoration? It is in lung abscess, bronchiectasis, necrotizing pneumonia, alveolar cell carcinoma, and if an empyema ruptures into the bronchus. What is the definition of bronchoria? If a person expectorates more than 100 ml of sputum per day, we call it bronchoria. And bronchoria is usually seen in bronchoalveolar carcinoma and also some other things where there is copious amount of expectoration. Color of the sputum as noted, okay, this is mucoid, mucopurulent, and hemorrhagic as I told. But here again, whether it is greenish or yellowish in bacterial infection, black in cold workers, pneumoconiosis, all of you know about the pink frothy sputum which is there in pulmonary edema. Rusty means a blood stain type, and it's just the color of the rust. It is usually seen in pneumococcal pneumonia. Red current jelly sputum in Klebsiella pneumonia. Blood tinge in definitely in any form of hemoptysis. Mainly here we have to think of tuberculosis and Ancovisos, which you have read in your pathology class because of a ruptured amoebic liver abscess. So coming again, the patient may tell that when I'm lying in the left lateral position, there is copious amount of expectoration, not when I'm lying light position. Or when I'm not using a pillow, I'm having copious expectoration. While using the pillow, I don't have any copious expectoration. So it is postural variation and the expectoration you'll be seeing in a lung abscess, in bronchiectasis. Smell is very important. So while foul smell sputum is there because of some anaerobic infections, bacteroids. This is usually seen in anaerobic lung abscess, anaerobic bacterial infection, mainly in bronchiectasis and other lung abscesses. Coming to the next symptoms, dyspnea, thus the subjective feeling of shortness of breath. Inquire about the onset, the duration, the severity, the aggravating relieving factor, the postural variation, the diurnal variation. These you should remember and have to write with each and every point, because this dyspnea exaggerate, but explanation is very important. Now, gradation of dyspnea. There are different gradation of dyspnea. You can, the cardiologists accept in some other form, the pulmonologists accept, but when you are dealing with a respiratory case, try to grade the dyspnea according to the Modified Medical Research Council scale, and this is very important. This is very easy, and this you have to memorize by heart. That is, the person is not breathlessness with strenuous exercise, there is grade 0. And the 4 is I'm too breathless to leave the home, or I breathlessness even dressing or undressing. That means the grade 4, the severe form of breathlessness. In fact, 1, 2, 3, you have to know there is 1, shortness of breath while hurrying on level ground or walking up a slight hill. It's very easy. Just remember, walking hill, uphill. There is grade 2, level ground. I walk slower than people of the same age because of breathlessness. This is 1, uphill to level ground. And 3, I stop for breath after walking about 100 years or after a few minutes. So this is very simple. Another way of explaining the breathlessness, which if you by chance forget this MMRC scale, but again, when you're writing the history of present illness and you are grading the dyspnea, try to mention it in the patient own language, but when you are summarizing it, try it in placing it in the MMRC scale. For example, if a person or patient tells that, doctor, I feel breathlessness only when I go to the washroom and come back from the washroom. You can write it in the patient own sentence. Or if a patient tells that, I feel breathlessness when I go to the post office walking and come back from the post office walking. So you can write in the patient own sentence. But when you are doing the summary of the case, then you have to write it in the modified medical research council, or the examiner may ask you, what is the gradation of dyspnea? In that time, you can tell it in the MMRC scale. So coming to hemoptysis, again, there are different ways of telling the hemoptysis, whether it is mild, moderate, severe, or massive, and there is clear-cut definition of that. Mild means less than 100 ml per day. How do you understand whether it is 100? You ask that, you just a tea cup if you place, you ask, is the bleeding more filling up the full cup in the whole day? Mild means less than 100. Moderate means 150. A cup is considered as 200 ml or so. So if it is filling up the whole cup, that means severe. All severe hemoptysis are to be attended immediately and admitted to the hospital. So severe hemoptysis that is filling up a cup, teacup per day means severe. Massive, what is that? 600 milliliter per day, or 100 ml for more than 3 days, or 150 ml per hour. This is considered as severe. So you should know what is the severity, gradation of the severity. This will help in triaging your patients. Chest pain. If the patient complains of chest pain, try to note where is the chest pain, that is localization. Onset means when it started, whether it is sudden in onset or insidious. The duration, severity, how do you mention the severity? I'm not going in details. This has already been discussed in other classes. For example, severity means you can just compare it with, say, toothache, or say some other pain, fracture, bone fracture, or labor pain or something. You can tell that if you compare with this pain, these are the severe most pain. Or even severity can be assessed in some other form, whether it is disturbing your sleep or not. Any pain which is disturbing sleep means severe. Character. How do you know the character? Whether it is pricking, stabbing, or dull aching, boring, whether there is any radiation. I'm not describing again in details, but you should note that associated symptoms, whether the chest pain is associated with shortness of breath, or any, say, headache or fever or something like that, aggravating relieving factor, diurnal, seasonal variation, and retrosternal pain is there or not. These are something which you should know. Just again coming to the, jumping from there to the examination examination of the general survey. I'm not describing in details the general survey, but some important points in the general survey for the respiratory system is a must, is the lymph node examination. I'll show a video on how you examine the lymph node. But when you get a lymph node, because this lymph node is very important, this lymph node may tell you, pinpoint you, whether there is a infection, for example, tuberculosis, whether there is a malignancy in the lungs, because the neck, lymph node in the neck, mainly the supraclavicular region, is very, very important. If you can get a lymph node, you practically come to a diagnosis, and you can get a histopathological sample from the lymph node and try to find out the diagnosis. That's very important. For example, a patient comes to you with cough, hemoptysis, and chest pain, and you find a supraclavicular lymph node here. So if you find the supraclavicular lymph node, you can get a histology, that is aspiration from the lymph node and immediately get the diagnosis whether it is tuberculosis or malignancy. So examination for lymph node, mainly the cervical lymph node, is very, very important. Definitely don't forget to examine other lymph nodes. The axillary lymph node is also very important. When you see a lymph node, site, number, whether it is tender, non-tender, discrete, matted, consistency, whether it is fixed, mobile, the condition of the overlying skin, or whether there is any sinus. Sinus points you that probably you are dealing with tuberculosis or something. Again, clubbing. So clubbing, causes of clubbing have been already discussed in length in different classes, but when you come to clubbing because of some pulmonary cause, try to describe it in some form. For example, one is congenital, other maybe because of the infective etiology or neoplastic etiology. So this is the way that you tell your examiner about clubbing, because I'm telling you, everyone tries to remember, tries to get some mnemonic, but the best way to convince that you are telling something very good way is, sir, one is congenital clubbing, other clubbing because of infection or pulmonary infection, which is bronchiectasis, lung abscess, empyema, and cystic fibrosis, neoplastic bronchogenic carcinoma, and unilateral clubbing seen in Padcock tumor, and other causes are interstitial lung disease. That's the best way that you can describe clubbing, and I'll be happy if some of my students, if I ask what is the cause of clubbing of pulmonary cause, if you tell in this way, you will be getting good marks out of it. So ultimately, from your history, from your general survey, you should have a anatomical localization, which part of the lungs is involved. That's the real beauty, and then you can examine properly whether the airways are involved, parenchymas are involved, the interstitium are involved, pleura are involved, the chest wall is involved, or the pulmonary vessels are involved. That's the way. If you get a very good history, general survey, you can know which part of the anatomical part of the airway are involved. So with this, I will come to the examination of the respiratory system, and as of any examination includes the infections, palpation, percussion, and auscultation. This is same thing for the respiratory system. When it comes to inspection, simply inspection is what you see. And when you inspect, always do, the first thing that you have to do is to definitely take a permission from the patient. If it is a male patient, try to expose the patient up till the waist. Definitely female patient is very difficult to examine. If you are male, that is if you are a person and you have to examine a female, try to keep a female attendant and try to examine the most decent way that you can do. That's my humble request, because you cannot embarrass the patient. And at least you have to have a screen if you are examining a female patient, the respiratory system examination. That is something at least you ask. Otherwise, the examiner may come you and scold, you are examining the female patient in front of everything. Why haven't you asked for a screen? If you should ask for a screen, and if your convener cannot give you a screen there, you can tell the sir, I have asked humbly that I have asked, but probably screen is not there. That's why I cannot get in. And but still, I am taking most of the step that I can do to keep the sick patients as of now. So you have to examine in the sitting, standing, lying down, and definitely adequate light should be there. And what you look for, this is very, very important. The size and shape of the chest wall and the symmetry of the chest wall. Movement of the chest wall, inspection also, try to look at the position of the trachea, but again in the palpation you have to confirm the position of the trachea. In fact, all examination depends upon the position of the trachea, what you want to get and what you'll be getting. The most important is position of the trachea and the apex, because whether the mediastinum is shifting in the same side or in the opposite side, that's the important. So involvement of the accessory muscles is also important. Visible scars, sinus, engorged vein, fistula tract. Again, most of you will get a pleural effusion in your lung case. If there is pleural effusion, one or many pleural effusion. So try to find out whether there is any scar mark of a prick where fluid has been aspirated. Don't miss that. So if you see a scar mark, you can tell there's a scar mark there. Examiner will ask you, what is the meaning of, what is the scar mark for? Sir, probably fluid has been aspirated from there. And you also know that if someone doesn't come and tell you or gives an hint, you know that this is if there is a scar mark there of a pinprick and aspiration has been done, you know that my case is a case of pleural effusion. Bony deformities, kyphosis, kyphosis and scoliosis has to be looked for. So if the chest is asymmetry, what does it mean? Either there is a drooping of the shoulder, where there is drooping of the shoulder, if there is pleuroparenchymal fibrosis and there is a pull, you can look for sinospinous, tip of the spinous process and the scapular distance, whether the is equal. In fact, you can look at the lower border of the scapula. You can look at the medial border of the scapula and the arm chest distance or the level of the nipple. These are way that you look at this symmetry or asymmetry, on other way you can call it. So just a bit about the normal chest, bilaterally symmetrical, elliptical in cross section, and the AP by transverse diameter is 5:7. So that's the normal chest. And you should know some terminologies of the abnormal chest. These are pectus carinatum or the pigeon chest as it is called, and forward protrusion of the sternum, straightening of the ribs in the front. And where do you see those? In congenital rickets, chronic nasopharyngeal obstruction. In fact, rickets is now rare, but in chronic nasopharyngeal obstruction and chronic infection, you may see pigeon chest even now in these times also. Alert chest. It's really difficult to diagnose. Undue prominence of the vertebral borders of the scapula, increased obliquity of the ring, but just to know it theoretically, that there is you may be asked in theory question also, what are the abnormal shape of the chest? Here you have to write, at least mention the alert chest, but practically, if you diagnosing alert chest is not that easy. But on the other hand, barrel chest and funnel chest are something common you may get in your examination for spot case, short case, spot case, or even in the long case. So funnel chest or pectus excavatum or cobbler's chest, it is something exaggerated hollow of the lower end of sternum. It may be seen congenitally. It may be because of an occupational as called cobbler's chest, because the cobbler just sits there and does his work. It may also see in Marfan syndrome. Just remember it. Barrel chest, it's very easy. Increase anteroposterior diameter, ribs are horizontal, sternum arched with prominent angle of Lewis. It is basically a circular cross section. How do you measure that? The anteroposterior and the transverse diameter, I will show you when we do the palpation part. Where do you see? Normally, the answer should be we see in hyperinflation of the chest, mainly in patients of COPD or emphysema. It may be also seen in old age sometimes or kyphosis of spine, but the answer should be the emphysema. Without saying emphysema, don't tell old age kyphosis. So pigeon chest, again, Harrison-Sulcus groove or depression. I'm not going on rickety rosary, bead-like enlargement of the costochondral junction. Theoretically, you should know this because if the abnormal shape of the chest comes in a long question, and scorbutic rosary, sharp angulation of the ribs, backward displacement of sternum, just to show you the normal chest here and the barrel chest here. This is pectus carinatum and this is pectus excavatum. Just see, this is pectus excavatum. These are something which are pictures taken from the books. Now again, asymmetry of the chest. It may be because of spinal deformity, kyphosis, scoliosis, or both together. Where do you get a unilateral, that is uniform bulging? If there is a bilateral pleural effusion, a pleural effusion pneumothorax, so or a compensatory hypertrophy. So localized bulging, if you see, definitely a part is bulging here on the chest wall. It may be because of an empyema which is come up to the skin, and that is called empyema necessitans, or a mask-like lesion which is protruded into the chest wall, and sometimes, rarely pericardial effusion may sometimes cause that, but still you don't try to mention. This is something which I have taken theoretically. Localized retraction, what do you see? It is seen in pleural thickening mainly, or sometimes in fibrosis in prolapse, or sometimes in muscle wasting. This is important. Movement of the chest, where the diminished unilaterally, maybe because of the pleural effusion, chest trauma, where there is the person tries to pinch themselves, in pneumothorax, hydronemo, consolidation, fibrosis. Bilateral, if there is bilateral hydrothorax, patients who are obese, in emphysema, patients who are hyperinflation because of asthma, diffuse interstitial fibrosis, or if there is neuromuscular weakness because of some diseases like myasthenia gravis. So this is something, again, you have to look for. What is this called? This is called trail sign. As I told you, position of the trachea is to be seen. So there is an undue prominence of the sternocleidomastoid muscle on the site where the trachea is shifted. This is called trail sign. Try to look for this. As I told, position of the trachea is very, very important in examination of the respiratory system. All depends upon where the position of the trachea is. So trail sign is something which you have to look for. Second important aspect of examination is palpation. Palpation normally in the sitting posture, may be seen in the standing posture. For apical upper zone, you put your hand over the apical region with thumb approximately in the middle. For middle and lower zone, I have a picture for that. I'm telling you, I'll show you a video of the examination, which is important, but today I'll be discussing a bit of theory so that you get to it and look at the video so that you can understand. For middle and the lower lobes, hands are placed on either side of the chest wall and thumbs are stretched to meet in the midline. You may touch, you may make a skin fold in the middle. So these are different ways. Just you look on one textbook and see what they are doing and try to quote when someone asks that who has shown it, where did you get it? At least you can quote one textbook, and one important, try to quote Hutchison, because this is the one which is off-read and all examiner knows. So what do you do on palpation? You have to confirm what you have seen in your inspection. So one side of the chest is moving less, so you confirm that. Position of the trachea. How do you do that? I have a picture for that, and it's very important. You have to examine the apex bit. Details of the examination of apex bit probably will be covered in your cardiology class. With that, there is chest expansion. I'll show you video where you see the chest expansion in the apical part, the supramammary, mammary, inframammary, and in the posteriorly, this intrascapular and the infrascapular. Measurements. How do you do the measurements? That's another important thing. Ideally, the measurements, for the measurement, you have to have a tape and two hard board. It may be some clipboards that will be there in your examination. So what you do for taking the anteroposterior diameter, place two hard board, anteriorly and posteriorly, and measure the anteroposterior diameter, and the transverse diameter, place to hard board just and the axillary side and measure the distance. So this is the way that ideally you measure. In fact, some other measurement may be how much the chest or thoracic wall is expanding on every inspiration and expiration. But the most important palpation is the vocal fremitus. So vocal fremitus and vocal resonance, they are two things which are practically many similarities. So fremitus is what you palpate. Vocal resonance is what you auscultate. That's it, very important. How do you remember? The mnemonic is F comes first, palpation comes first. So vocal fremitus is something what you palpate. So you may tell this patient to tell thin, thin, thin. You apply the same hand, and ideally you should palpate the vocal fremitus with the prominence or of your. Try to apply the same hand on, immediately compare it with the symmetrical area on the opposite side. Normally, you see the normal side first. If you know that probably right side is normal, left side is more normal, do the normal side first, then the abnormal side. Compare symmetrical area. Where it is increase in consolidation or even in fibrosis. Where it is decrease in fluid or air in the pleural space. That's very important, and immediately the examiner will ask you if you say the vocal fremitus is increased. So what is your thought process? It may be consolidation or fibrosis. If you tell the examiner that is the vocal fremitus is decreased, the examiner asks you what will be the cause. Normally it is because of pleural effusion, or even if you get a pneumothorax. You should look for rib crowding, you should look for localized swelling and tenderness. This is how you look at the trachea. In fact, just place the, it's with different people, some place the middle finger, but I prefer to place the index finger. Just you see, and just you can look at which side your fingers insinuates more. You can just, what the most important thing to fill the trachea is put your finger just over the suprasternal notch and see on which side your trachea, is it in the middle or is it just touching your right lateral or your left lateral. That's the best way to see. And you can insinuate your hand between the sternomastoid muscle to see whether which side of the sternomastoid muscle your finger can insinuate. This is practically most important thing. So shifting of the trachea with the disease process. So if there is a disease on the right and the trachea is shifted to the right, we call ipsilateral shifting. So a disease on the right side, shifting of the trachea on the right side means ipsilateral shifting. So where do you get ipsilateral shifting? This is something you have to memorize: fibrosis, collapse, and pneumonectomy. Where do you see a trachea being shifted to the opposite side? Mediastinal shifting, pleural effusion, pneumothorax, hydropneumothorax. Even if a mass is also pushing up the trachea. So this is something which is simple and you have to memorize it. Don't forget. Coming to chest expansion. This has been discussed: bilateral decreased chest expansion, unilateral decreased chest expansion, unilateral infusion, pneumothorax, collapse, fibrosis, bilateral in empyema, hydrothorax, bronchial asthma, or in neurological disease, myasthenia gravis. Coming back to our percussion. So two types of percussions are there: diagnostic and topographic, or determining the boundaries. Diagnostic means whether there is any air or fluid. I'm not going to history where the how the percussion started. In fact, it all started when barrels of wine was percussed to see how much of wine is left. So again, I'm not going in details to the history, but still what is important is it should be in the sitting or in the standing posture. The comment may be done. I will come to that. So the two important terminology is what is the pleximeter finger and the placer finger. The pleximeter finger, usually the middle finger of the left hand, should be firmly placed and is on the chest wall along with the intercostal space with no interposed air pocket, and firmly. How well you percuss tells you how well you attended your clinical classes, because one who percusses well, examiner will know that he is very expert and usually attends the clinical classes. So the pleximeter fingers should be firmly placed on the chest wall. Other finger must be held away from the chest. That is, if you see this, your hand, if you can see me, I don't know whether if you can see me. Let me see whether you can see me. So if you just see here, this finger, the pleximeter finger, will be placed firmly without any air pocket, and the other fingers should be lifted up here. If this is the chest wall, if I think of, and the placer finger, the middle finger of the right hand, should hit the middle phalanx at 90 degrees with the pad of the finger, this pad of the finger. And the most important is it should be from the wrist joint. I have seen people doing it from the shoulder joint, from the elbow joint, anywhere, but it should be from the wrist joint, this wrist joint. That is very important, okay? And the force of the stroke varies on the thickness, the age, gender, the area of the chest wall percuss. For example, if it is a fat young lady, so you have to percuss hard, and if it is a thin-built person, a young person, tender percussion is there. So area must be equidistant from your each ear. Sometimes some people will put up their ear beside and on the right side, and in the left side they are putting away. This should not be. When you percuss, it should be equidistant from both ears. That's very important thing. So this is how you do this, and we'll show a video of percussion. This is very important for this. So sequence, how do you do the percussion? So first is that direct in clavicle, you need not put the plexiform finger, just direct medial 1/3 and lateral 2/3. You see here, you see here, and compare it immediately with the other side. You see whether there is, what note is there, whether there is any abnormal percussion. Have to look for the cardiac dullness, had to look for the liver dullness at the mid-clavicular, mid-axillary, and the scapular line. I'll come to the trop space. I'll come to the shifting dullness in a bit. So I'm telling you, normally it is a resonant note, which is a low pitched, and the lesion, in fact, if the lesion is more than 5 centimeter depth, you cannot have that. Or if the lesion is less than 2 centimeter, you may not alter the resonant notes. For example, even if a lesion is there in the lungs and it is more than 5 centimeter deep, you may still get a resonant note. I'm telling you, tympanic means a hollow viscous. You never get a tympanic note in the thorax, but you get a tympanic note in the abdomen. So what will happen if you get a tympanic note? Rarely, that means some of the hollow viscous has entered the thorax in diaphragmatic hernia or a diaphragmatic rupture in, say, for example, a road traffic accident. Subtympanic or hyperresonance with a boxy quality, it is usually seen in just above the pleural effusion or in consolidation. Hyperresonant is very important, is immediately, it is, say, I'm telling you, hyperresonant in intermediate in pitch between a resonant and tympanic. It is usually seen in pneumothorax, large bulla, compensatory emphysema. So the normally hyperresonant is seen in pneumothorax. That's the important. In long case, if you see a patient who is having hyperresonant, think of pneumothorax. Theoretically, you may know large bulla compensatory emphysema may cause hyperresonant, but in your examination purpose, in a long case, if you see a hyperresonant, always think of pneumothorax. Where do you get an impaired note? Dull note. If there is a fluid, if there is consolidation, if there is collapse or fibrosis. Mass, fluid, consolidation, collapse, fibrosis. It may be dull, stony dull, it may be woody dull. Woody dull in consolidation, collapse, fibrosis. In stony dull is usually seen in pleural effusion or a tumor mass-like lesion. So again, dull, when you see dull, woody dull means as if you are percussioning on a table, woody dull. Stony dull means as if you are percussioning over a stone. You have to know or feel the difference. It's the feel. Again, theoretically, because this is something which you cannot get in real life, where do you get a cracked pot resonance? Normally elicited over the chest in a crying infant, definitely, but a large cavity in communication with a bronchus due to sudden expulsion of air from the cavity may cause a cracked pot resistance. What is a cracked pot? Usually, if you see in the villages, some earthenware pots, they see whether it is, whether there is any crack or not by percussioning it. Normally, a crack pot gives a type of sound which you immediately recognize whether there is a crack or not. So this crack pot resonance is seen normally if there's a lung is communicated with a bronchus, lung cavity. So this is something theoretically you should know, but practically you may not get. So again, trop space. Trop space, I'm not going in details. This is an anatomical because we cannot finish up that, but it's basically the fundus of the stomach, the boundaries. Practically, you know in your anatomy classes, it may be asked in your examination, but again, the boundaries, it is area of the resonance below the costal margin, liver on the right, spleen on the left, and basically it is the fundus of the stomach. You may sometimes ask about the trop space, and sometimes maybe asked about the boundaries of the trop space if your examiner is, tries to pull your leg in that way. So shifting dullness is something which you all have to elicitate if there is a dullness. So where do you get a shifting dullness? Where there is free fluid. How do you do the shifting dullness? You go on percussioning, get the dullness, put up the finger, put the finger there. In fact, you can have a mark with a skin marking pencil with permission from the patient. Go on percussioning, at least you see full dullness. Then you tell the patient to, in the position, take the position of Mohammedan prayer position. The patient takes the Mohammedan prayer position, and then again you percuss to see whether this dullness that was there and the glass marking pencil that you have been there, it's called the skin marking pencil, whether there is any shifting. The simplest way is to do, hold up the place or just don't move the plexiform finger from the place. Make the patient in the Mohammedan prayer position. And how long should you wait? There are different texts which are quoting how long. Normally it is 2 minutes or so. So 2 minutes is sufficient to move up the fluid and then again percuss. So this is something which I have already told. Don't tell tympanic in thorax. It is usually seen in hollow viscous. Resonant is the normal lungs, hyperresonant in pneumothorax, subtympanic level of pleural effusion, impaired in fibrosis, woody dull or dull even in consolidation, stony dull in pleural effusion or any other effusion pneumothorax. Last part of our examination system is auscultation. Again, it should be in the sitting, standing, deep breathing with the mouth open. The scheme is you have to see whether there is any breath. Sorry. So let me just switch off my phone. Okay, so auscultation, we have to see whether there is any vesicular breath sound or not, whether there is any abnormal breath sound, there is a vocal resonance, whether there is any added sound or not. So vesicular breath sound, what is the vesicular breath sound? It's just the sound of the rustling or the breeze quality. It's a low pitch rustling sound. So what is important here is a louder inspiration, inspiratory, expiratory, just let me. So inspiratory, expiratory is important. 3 to 5:1. No pause is there. That's the very important issue. It is characteristic in the axillary. This is the normal breath sound and the infrascapular region. You have to know the bronchovesicular tracheal sound similar to the bronchial sound. The bronchovesicular breath sound intermediate in quality between tracheal and the vesicular, and normally heard at the upper part of the sternum. So these are something which you have to know about it. Abnormal breath sound are important. Loud vesicular breath sound in thin chest wall and in compensatory eczema. Where do you get a reduced breath sound? Definitely if there is patient is having pain and not moving the thorax, if there is some pleural pathology, if there is a pericardial pathology, or the respiratory muscles are not moving because of some neuromuscular disease like poliomyelitis, emphysema, decreased lung elasticity, the lungs are not moving, decreased conduction of breath sound, for example, in pleural effusion, pneumothorax, pleural thickening. So now coming to the bronchial breath sound. It's a high pitch, the inspiratory expiratory ratio being 1:1, and don't tell a gap between inspiration and expiration. It is a pause between inspiration and expiration. So there is inspiration, a pause, and then expiration. Again, the bronchial breath sound may be tubular, maybe cavernous, maybe amphoric. Okay, so this is something, again, for theoretical purpose, it is really difficult to understand clinically what type of bronchial breath sound, whether it is tubular or cavernous. But again, if you train your ears, I don't expect from an undergraduate student whether he will be telling me tubular, cavernous, or a amphoric. But if you train your ears and hear 10 tubular, cavernous, you can distinguish that, yes, sir, this is a tubular. And if it is a tubular, you can tell that probably, sir, this is consolidation. So where do you get tubular? Tubular is usually a high pitch you see in consolidation. That's the only thing you remember. So where do you get a cavernous? It is of the lower pitch. It is a hollow character. If there is a cavity with irregular border, open pneumothorax or pulled trachea sometimes. So where do you get a cavernous? You tell open pneumothorax or a cavity. That's the thing. Where do you get an amphoric? It is again, you see tubular is high pitch, cavernous is low pitch, and amphoric is again high pitch. Amphoric means echo-like, it's metallic quality. Where do you get such thing? Larger cavity with smooth walls in pneumothorax communicating with the bronchus. To me, it's the metallic quality that you train your ears and hear. Amphoric, understanding amphoric is easier. So it's something metallic. So this is something vesicular, bronchovesicular, and in bronchial, and tracheal and bronchial is something same. this pause, inspiration, there is a definite pause between inspiration and expiration. So now coming to the added sounds, you have to tell whether there is any added sound or not. Added sound include the wheeze or the ronkai. In fact, there are different texts classifying the difference between wheeze and ronkai. I am telling you, this difference is not that much. They are all synonymous, wheeze and ronkai. Sometimes people tell audible wheeze is audible ronkai is wheeze. The person, you can hear the wheeze from your ears. It is basically a continuous musical sound produced by the flow through the narrowed airways. So they are produced when air is forced past a point in which there is opposing wall or just touching. These distinguish monophonic and polyphonic wheeze are very important because you can localize your disease. So if it's a monophonic, whether it is fixed or random, and polyphonic, it is expiratory or both during inspiration and expiration. So fixed monophonic wheeze is a constant pitch, timing, and sight produced when air passes at high velocity through a localized narrowing. So if there is a monophonic fixed wheeze, always think probably there is an obstruction in a localized obstruction. It may be mass, maybe a foreign body, or a lymph node obstruction. So predominantly in expiration, predominantly in inspiration. It is in the laryngeal obstruction or expiration, lower trachea. I'm not going in that. What is the difference between a polyphonic? Expiratory, this is polyphonic, usually is seen in obstructive lung disease, mainly in asthma and COPD. So polyphonic wheeze means that the whole of the lungs are involved practically, and most of the lungs are involved, and polyphonic are seen in obstructive lung disease. So monophonic means there is localized obstruction, polyphonic means there is generalized obstruction. I'm not going this way. Coming to crepitations, again, what are crepitations? These are interrupted, short, sharp, non-musical. That's the difference. And how does it happen? There are different theories into it, but probably snapping open of the airways causes sudden equalization of pressure when a closed airway separates two adjacent compartments of the lungs. They may be found in early inspiration, late inspiration, or expiration. So you should know the differentials. Early inspiration, normally COPD, or sometimes arises from a large airways, coarser, and not related to posture. Late inspiration, that's very important. Late inspiratory wheeze in interstitial lung disease, and the typical terminology that we use in interstitial lung disease crepitation is Velcro crepitations. In pulmonary edema also, late inspiratory, clears on cough, no change on bending forward. That's another important. Expiratory wheeze in severe airway obstruction or airway obstruction also. So ILD wheeze is called the Velcro crepitation. Rub, pleural rub due to rubbing of the two pleural surface, commonest site in the lower part of the axilla. Again, you should distinguish the crepitation and pleural rub. It is by training your ears. There are theoretical ways that you can distinguish the pleural rub. Just splinting the pleura may decrease the rub, or the just like a leathery feeling is of the pleural rub. Sometimes it is very difficult to distinguish pleural rub with crepitation, but it is better to move for crepitation if you are really not in a doubt whether it is pleural rub or crepitation. So what is succussion splash? Again, it's an auscultatory. For example, if there is a hydropneumothorax, as if a jar is there, fluid and air is there. If you suddenly jerk the jar with fluid, you will see a chalak awaaz, a sound. That's the succussion splash. The splashing sound heard when a stethoscope, when the chest of a patient is suddenly shaken. This is seen in cases where there is fluid and air. This is usually seen in hydropneumothorax. Even if a person has drunk water, the fundic and the fluid in the stomach may mimic as a succussion splash. So you should know that whether the succussion splash is coming from the stomach or not. Now coming to the vocal resonance. Vocal fremitus has been given. You have to know about the vocal resonance. So the organizer, please tell me how much time is left for me. Organizers, can you tell me how much time so that I can?
Actually, sir, you can carry on because We have no time constraint, brother.
Okay,
Because
so I will take another say 10 or 15 minutes time. If it is okay, then if it is comfortable for all of you, then it's okay. Okay.
Fine, sir.
Yes, sir.
So I can still see 65 participants are there. So coming to the vocal resonance, it is auscultatory equivalent of the tactile vocal fremitus. Again, I'm telling you, vocal fremitus is what you palpate and vocal resonance is what you auscult. Heard as weak, muffled, indistinct sound, loud and clear over the trachea, lower in the suprasternal area, intrascapular and area in the C7. So what do you get? A increase and a decrease. That's very important, and that's the real thing that your examiner will be asking you. So vocal resonance is increase in, you may make any mnemonics out of it, but you should know the theory behind it. So increased in consolidation, increased in superficial cavity, increase in compensatory emphysema. Where do you see decrease? In pleural effusion, in pneumothorax, and in thickened pleura. Where do you see absent? A large pleural effusion or a pneumothorax. So this is something which you have to know theoretically and basic, not making up mnemonics out of it, but knowing the theory out of it. Now, two important terminologies should be known when you ask vocal fremitus resonance. One is the bronchophony and the egophony. What is bronchophony? Spoken voice sound are unduly loud and clear, although still indistinguishable. So this is bronchophony. What you do, tell the patient to tell tin, 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 and then you hear or any other, if you say tin, 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 or 666, 999, anything you can tell. The bronchophony is usually seen in consolidation. That's the important thing. Some people may tell it is seen above the level of a pleural effusion, but to me, it's seen in consolidation. If you see a bronchophony, think of consolidation. What is egophony? It's something as a nasal quality. You can see the sound, but it's a nasal quality, like the breathing of a goat. And it is seen usually in a cavity filled with secretion. So above the level of pleural effusion, bronchophony, egophony, anything can happen. But bronchophony, consolidation. Egophony, cavity filled with consolidation. So again, whispering plectral-leaky. If the patient is told to utter in a whisper, the whispering voice sounds are transmitted to the chest wall with clearly distinguishable syllables. It is usually seen in cavity communicating with a bronchus or even a consolidation. So level of pleural effusion is anything, I'm telling you. The level of pleural effusion, people will be telling anything. So with this, practically, in a nutshell, this is something about the examination. But again, clinical examination is not the end of it. We should go into the imaging studies. Practically, we can take a class on all of this. What are the imaging? For example, when you know from the history, the general survey, and the chest and the examination part, that these are the things you narrow down the anatomical localization, see what are the physiological changes that are happening. For example, if you see that the chest wall is abnormal on the right side, the trachea is shifted to the other side, and there is dullness on percussion, then you know that it is a pleural effusion and it has shifted the trachea to the mediastinum to the other side. So you require some investigations to find out what are the normal studies or imaging studies that we do in respiratory diseases. They are routine chest X-rays, which include the chest X-ray, posterior anterior view, lateral view, and by protocol, the left lateral is taken. Then comes the CT scan. It may be a high resolution scan or a helical CT scan. MRIs are not that very important. It is an important imaging for the neurological system, but not for the chest. We have the PET scan to detect whether a tumor or a mass lesion is high emitting PETs, whether it is malignancy or not. But what is important again is use for pulmonary emboli is pulmonary angiography, ventilation perfusion scan. But here I should mention that a spirometry is very important, and for you undergraduate, with without knowing spirometry and without doing a hands-on spirometry, you are not expected to practically being appearing for the final MBBS. Now comes the ultrasound, the virtual bronchoscopy, by a CT scan, and then I'm not going to lung physiology right now because I have to end up here. We can go on lung physiology because I will be expecting some questions that will be asked from your side. But again, the bronchoscopy, thoracoscopy, and other invasive investigations, which include a percutaneous needle aspiration or an EBUS, that is endoscope guided bronchoscope, that are important as an investigation tool for diagnosis. So I should end up here asking for some of the questions, and I will stop sharing my slides so that I can get some questions from you. So Somabroto, how do you now conduct this session?
Actually, sir, thank you.
I cannot hear you, Somabroto.
A lot, sir, for such a elaborated discussion. As a sir, can you hear?
Yes, I can hear you right now.
Mm-hmm. Okay. Actually, thanks. First, I would like to thank you. A very elaborate and nice presentation. Even on my side, I have once again recapitulated many things which I have read in final MBBS, and even as a practicing general practitioner, also many useful and informative information I have received from your side. And definitely it will be of help for the students. But I would like students to actually come up with the chat messages, because if whatever the questions are, if they send it in chat, actually it will be easier for us to see and also and for you to answer. So I would like to ask the students, whatever queries you have, please send it in chat if possible. Or otherwise, you can also may go for direct questioning, because chat questions will be easier.
Sir, one question is there.
I have seen the question. So people are trying to ask between how do you differentiate pneumothorax from bulla? Again, I'm telling you, for undergraduate people and even for postgraduate people, I've seen Ponna joining, my love joining also there. So I will be telling you, see, for clinical purpose, I'm always don't try to distinguish between a bulla and a pneumothorax. So what you are getting on percussion, that's the very important, whether it is a hyperresonant or not. So if you see a hyperresonant, you think that there is some air in this in the pleural space. Don't try to comment that it is bulla. If the examiner asks you what may be the differential of this, you can tell that it may be a bulla, sir, a huge bulla that is causing the hyperresonant there. So that's the important thing. In fact, it is even very difficult for us to distinguish a pneumothorax from a bulla, even on a radiological examination, that is this high resolution CT scanning. So it is not very simple. Even it is difficult for us to distinguish from a bulla and a pneumothorax in a CT scan. So clinically, no way to differentiate. You have to tell that for your clinical purpose, both for undergraduate and postgraduate, this is a pneumothorax. So how do you differentiate between bilateral pneumothorax and emphysema as both are hyperresonant? Okay, the basic thing is you don't get a bilateral pneumothorax in a case in your final MBBS or even in a postgraduate examination. I'm telling you. So why the patient will die if an intercostal chest tube is not given to that patient? So it's an emergency, real emergency. Probably practically in my lifetime, I have seen only one case of bilateral pneumothorax in a young sister, in fact, of our hospital when I was doing my postgraduate, and that intercostal chest tube was given in that place. It was because of a miliary tuberculosis. On such kind of disseminated disease, you don't get bilateral pneumothorax. So again, for theoretical purpose, if you are in the emergency and if you get a bilateral pneumothorax, how do you distinguish? There will be absent breath sound, but in emphysema, there will be breath sound. So that's the real way to distinguish between an emphysema versus a pneumothorax. So will bulla not? So in fact, if you percuss on a bulla, the bulla will not rupture. So percussion only. So people examiner may ask you what may happen or what is the problem of percussioning. In fact, it's not an undergraduate but postgraduate student may be asked that what may be happen if there is a percussion. For example, if a person is in atrial fibrillation and there are clots in the heart. So on percussion, you may dislodge the clot. That's the thing. So cardiac percussion should be done really safely, and you have to take caution of that, the cardiac percussion. You have to see whether the person is in atrial fibrillation or some clots may be there in because of the atrial fibrillation or some other disease of the heart, if there is a say infective endocarditis or some diseases of the heart. So cardiac percussion should be taken with caution. Otherwise, percussion is very safe. Even in a bulla, if you percuss, there is no chance of rupture. So which areas of the lung field you auscultate? That's it. See, ideally, I'll be showing a video of that. I've basically discussed the theoretical part. So when you auscultate, always compare one side with the other side. When you auscultate, at least wait for 3 inspiratory cycles, the respiratory cycle, inspiration, expiration, at least 3. Whenever a examiner tells you, just auscultate in front of me, what the student does is put up the stethoscope here for 1 or 2 seconds here, 1 or 2 seconds here, 1 or 2 seconds here, 1 or 2 seconds here. The examiner immediately understands that he is just taking in front of me, he is not auscultating. So you have to auscultate at least for 3 respiratory cycles. How do you do? It is usually in the supramammary regions, 1 or 2 areas, mammary region, 1 or 2 areas, in the medial and the lateral part, and the inframammary regions as you divide. So when you tell your examiner, so there is bronchial breath sound. If you see, for example, if you see bronchial breath sound in the supramammary on the right side, both medially and laterally, or in the mammary region, laterally and medially. This is way how you classify it. Or you may tell in the midclavicular line, medial to the midclavicular, lateral to the midclavicular, axillary, upper, mid, and lower axillary region. That's the way you auscultate, and always compare with the opposite side. Suprascapular, intrascapular, and the infrascapular, medially and laterally. That's the way, or you classify the, divide the areas and then auscultate. So again, left ventricular failure, pulmonary edema. It is in pulmonary edema that you see pink for the sputum. So I'll be showing you definitely. I do have the videos. I have made the videos, and practically I thought of giving you a theoretical test of the examination. Then I'll come up with some videos and or real life Zoom classes. I'll be taking my help of my PGTs who will be doing the video and showing real life cases how we examine, and take up the videos or even real life where people can. So it should be taken during our what duties hours, so that I can take help of my postgraduate students there who can show you, or a live chat on live discussion on the videos of the examinations of the patients. So any further questions?
Sir, I have a question, but it is not entirely practical oriented. It is a bit clinical. So can I ask?
Yes, Purna, please.
Sir, if a patient comes in the emergency, it is a severe asthma, and as we know that severe asthma can have a silent chest. So apart from dyspnea, what are the things that should make us think that, well, this can be a severe asthma? We are auscultating, we are getting a silent chest, the patient is having severe dyspnea. How should we think that it can be a case of asthma?
So again, Purna, as you mentioned that a silent chest, is it because of severe obstruction in the airway or something other than? A patient who is having a silent chest, something very emergency, we call it near fatal in that way, because if the patient is immediately not shifted to the ICU and resuscitated, the patient may even go to severe respiratory failure and even succumb. So all other features of hypoxia and hypercapnia may be developing in that patient. So what is the features of hypoxia? The patient will be irritable. In fact, there may or may not be cyanosis. Or if the patient is having hypercapnia, you can see the flapping tremors there. You can see the drowsiness that coming in after the irritability, that is the hypoxia. The patient goes in hypercapnia. Initially, the patient was very restless, just sitting up, getting down, pulling his IV fluid and pulling up these clothes and bed sheets, and immediately slowly and the patient slowly goes into, say, drowsiness. That means from hypoxia, the patient is gradually developing into hypercapnia. So silent chest will come with all features of respiratory failures in that way. You may see cyanosis, you may see hyperactivity and then drowsiness, and it have to have the history, whether the patient has respiratory distress or not.
Okay, sir.
So any further questions? So now that we have covered most of it, probably we should leave.
Sir, am I audible, sir?
Yes, yes, you are audible.
Just one short question, sir, from my side. I am Somo.
Yes, please, Somo.
Just one line, sir, because as we have covered every aspect, just I would like to have one or two words from you regarding the take-home message for students for the chest symptoms in COVID-19, because I think this can be a common question in Viva or.
But I didn't get your question. The question.
Yes,
what is the question, Somo?
Sort of question as
take-home message for the.
Sir, the question is any take-home message regarding COVID-19 symptoms in chest for students.
So how can they remain same? That's the thing. Are you telling the how can they remain same, or the take-home message is that see chest or your chest symptoms of COVID-19 patient. Okay, the chest symptom. See, ultimately, I understood. You have written. You have typed it down. The chest symptoms of COVID-19 patient.
If there any. Yes,
okay,
sir, yes, sir. Exactly.
Let me just highlight you. See, COVID is now thought it is not only that it is involving the respiratory system, but it's something of a systemic manifestation. You can get neurological manifestation even. Loss of sense and loss of taste is because of the neurological impairment. We have seen Guillain-Barré-like syndromes in COVID also. So when it involves the respiratory system, it may be in a minor form the symptoms of upper respiratory tract infection, that it may start with running nose, itchiness of the nose and a sore throat. And that's all, it may finish up with that. It may be like a mild respiratory, lower respiratory infection in the form that the patient starts coughing and a bit of shortness of breath. Or it may develop into severe form of pneumonia, viral pneumonia, which you see on auscultation, maybe few crepitation, but which is more prominent on the chest X-ray with patchy alveolar opacities and diffuse patchy alveolar opacities, which on CT scan you pick up very clearly by the ground glass appearance, some fibrotic strands, and there is homogeneous, that is non-homogeneous, or some homogeneous patches all over the lungs. And that you classify in the CT scan by the severity index. That is how much lobes are involved out of 25, which part of the lungs and how much it is involved, the severity, the mild, moderate, severe. That is out of 25, how much is the lungs are involved, or by the CODAD score, CODAD 1, 2, 3, 4, and 5. CODAD 5 means that it is most similar to COVID-19. CODAD 6 means that is the RT-PCR is positive. And CODAD 1 means it is not like COVID-19. So there is the CODAD score, there is severity scores, and the symptoms may be the person may come with, if there is a pneumonia, upper respiratory infection, the person comes with running nose, sore throat, some sort of cough, fever. When it goes to the lower respiratory infection, patient presents with cough, shortness of breath, and hypoxia. Another very important feature which we have seen in COVID hypoxia is that they are called happy hypoxic. That means the patient, you can see on pulse oximetry that the saturation is decreasing, but still the patient may not complain of the shortness of breath or dyspnea. And this is very serious and it is to be immediately taken into account. We have to do a high resolution CT scan to look for the involvement and shift the patient to a better place, or where we can at least maintain their saturation by initially with nasal prong, high flow nasal oxygenation, or some sort of non-invasive or invasive ventilation. So that's all.
Thanks a lot, sir.
Thanksgiving.
Okay, I think that
Thank-
everyone should get a copy of the presentation, because these are some theoretical discussion. I'll be sharing with the videos with explanation of how the examination is done. But as of now, I think that each one of you can get the presentation, PowerPoint presentation.
You
Mainly
can
for the-
upload it as a file here itself in the chat.
I'll do that. So thank you everybody. Okay.
Thank you, sir. So Amit, any last word of concluding words for today's session? Thanks a lot, students. Everybody, thanks a lot, sir. Thanks a lot, every student.
Thank you everyone for being in the class. The next class will be on 15th, this same time. Dr. Arunima Ghosh, MD Secretary, will be taking the class on tests of memory. Thank you everyone.